हेलो हाँ स्टार्ट कर।
Good evening, everyone. Today, this class is a case presentation. So, what exactly is the case? We'll see as we go by. So, a 64-year-old hypertensive male presented to ophthalmology OPD with complaints of diminution of vision in the right eye since 2 months. On examination, his uncorrected visual acuity was 6 by 36 in the right eye, and with his own glasses, previous glasses, it improved to 6 by 18, and the best corrected visual acuity was found to be 6 by 12. In the left eye, the uncorrected visual acuity was 6 by 36. And the best corrected visual acuity was 6 by 9. We can see the keratometry readings here. There is a difference of about 5.25 in the right eye. That is, there is a and around 3.75 in the left eye. On examination, the anterior segment, that is the conjunctiva, cornea, iris, and pupil, were found to be normal in right and left both eyes. The right eye had grade 1 NSP, nuclear sclerosis, and posterior subcapsular cataract, whereas the left eye showed early lens changes. The fundus was normal in both the eyes. So this is a fundus image of the patient. This is the OCT scan. This is the IOL master. So IOL master, because he was to be posted for cataract surgery, IOL master was done. As you can see in the IOL master readings, the lens power was found to be 18, and there was a toricity of 6 diopters at 169 degrees. So basically, the patient required a toric IOL. This was a pentacam image of the right eye and the left eye. The toric axis and the IOL was calculated. This is a Barrett's toric calculator. This is available online. What it is, basically, we'll be seeing later. So as you can see, 17.5 was the IOL power, and the toric cylinder was found to be 6, and the axis of the toric IOL was found to be 169. So, based on all of this, the patient was posted for cataract surgery, and a customized toric monofocal lens, Ultima Smart Toric from the care group, was suggested for the patient, and he underwent right eye phacoemulsification with foldable IOL implantation. Now, when the patient came for his first week follow-up, 1 week post-cataract surgery follow-up, there was the uncorrected visual acuity was found to be 6 by 18. And the autorefractome, the AR readings showed a minus 4.75 cylinder. And the best corrected visual acuity was also found to be 6 by 12. So this was a little odd, and hence eye tracy was done for the patient. So basically, eye tracy uses the wavefront aberrometry, and the intraocular astigmatic axis of the patient was recorded, and the actual axis of the IOL inside the eye was calculated. So this is the eye tracy reading. We can see this, the internal map or the wavefront map is that of the lens. The cornea wavefront map is the corneal astigmatism, and we can see that the toric lens power and axis that was in the eye was 5.97 diopters at 18 degrees, and the current entire eye astigmatism was found to be 5.69 at 135 degrees. So the tracy refraction, basically, tracy gives the eye tracy gives a refraction as to what is in the eye. So basically, the internal and the corneal astigmatism totally will give a refraction of plus 3.25 diopters and minus 5.62 at 45 degrees. So there was a 30-degree rotation, that is 4.98 diopters of change in cylinder power was found because of this rotation. So once we redial the toric IOL, the predicted post-rotation refraction would be around minus 0.71 diopters at 168 degrees. So then the patient was then again sent home, and 15 days after the right eye cataract surgery, the left eye cataract surgery was planned, and he then came for the left eye 1 week post-op follow-up. And on that follow-up visit, again we can see that the right eye showed the cylindrical error, that is minus 4.75, whereas the left eye showed an uncorrected visual acuity of 6 by 9. So the right eye IOL redialing was planned, and this was 3 weeks post the right eye surgery. So this is the video of IOL redialing. As you can see, the lines, blue lines basically are the Callisto system, which is showing the orientation of the axis. That the corrected orientation of the axis. So now we can see that since it was 3 weeks post-op, the initial incisions were opened. No new incisions were made. Uh, Viscoelastic was injected. And very gently, the capsule and the IOL, they were separated from each other. A little amount of viscoelastic was injected below the capsule to aid the early separation. And now the separation is confirmed. And this is the Callisto system, which is showing the actual axis where the IOL should have been. So now we are redialing the IOL to the correct axis. So after this, the visco wash was done and the patient was closed up. So the Callisto system that I was telling you about is an application of new virtual reality based technology that theoretically has the potential to optimize the alignment of artificial IOL and achieve optimal refractive outcomes. It has been proven that digital systems, marking systems, provide better results than manual marking systems. And also it is faster for intraoperative IOL alignment and thus reduces the overall surgical time. Now this is the patient's optometry on 3 days post IOL redialing. We can see that the uncorrected visual acuity is 6 by 9 and the cylindrical error has been reduced to minus 0.50. 1 month post-op, we can see that the uncorrected visual acuity is 6 by 6. The patient now does not need any vision correction, or he only needs a near add. So that was the case. So basically, it was a case of toric IOL implanted, and at 1 week post-op, the patient came back with a toric IOL rotation. So we'll start with a brief introduction to how to calculate toric IOL, what are the various methods of marking, and then we'll move on to what exactly caused the malrotation, exactly caused the rotation or malrotation of the toric IOL, and what steps we can do to prevent it. So this is a slide which is showing the toric IOL calculation. There are various formulas. As we can see, the top left formula is the EVO formula. That is emetropia. I just forgot. So it is a EVO formula. It basically considers the anterior and posterior corneal curvature, CCT and IOL geometry. It is a thick lens formula. So I used the readings of the patient and tried to calculate the IOL axis and the IOL power. So we can see it was 18 and 6 at 169 degrees. Similarly, there are other formulas like the Barrett-Toric calculator, which is very popularly used. And other IOL companies have their own brands, have their own formula. For example, Alcon uses a Barrett's toric formula itself, whereas Techniques uses the Holiday's formula. Holiday's formula uses axial length, keratometry, white to white distance, lens thickness, and ACD. Whereas the Barrett's basically is a Barrett's formula is a theoretical eye model, which calculates ACD related to axial length and keratometry, and the ACD is determined by the relationship between A constant and lens factor. Now this is a slide which is showing toric IOL axis marking. These are manual methods. So as we can see, the first one is Toric Patwardhan. So in this app, basically what we do is take a image, take a snap of the eye, then we zoom till the cornea reaches the outer circle. Then we press on the proctor. There's a proctor button on the right lower part. So we click on that button, and then we place two dots on the cornea, and then we enter the placement, and then we will get the um, basically the dot from the dots, where exactly are we supposed to place the IOL. So basically, if these are your red dots, and the blue line is the axis where exactly the IOL should have been placed. So that will show the error in the marking. Similarly, other methods are the Mendes ring. So it is uh, a ring which has degree marks calibrated on it. So you can mark the 0 and 180-degree axis. Pendulum marker also uses the same, is used for the same purpose. This is the bubble marker. We can see there's a bubble in between, so it will give you an idea of whether you are holding the instrument correctly or not. And uh, lateral, nasal, and inferior markings can be done. The Devgan axis marker, basically it is a hollow core. It is to be mounted on an applanation tonometer, and it is a hollow core that affords unobstructed visualization and accurate centration of the corneal markings with the pupil and visual axis. However, in this method also, if the patient sits tilted or he moves his head, it can be wrong also. Then these are the digital methods. There is Varion and Callisto. What we saw in the video was Callisto. So basically what Callisto does is IOL Master 700, when we are doing an IOL Master of the patient, the machine will take an image of the eye, and will the image of the eye is then shared with the Callisto system, that is the microscope, and at the same time the limbal vessels or any landmarks are overlaid on each other, and thus the axis is confirmed. A Varion system also uses the similar method. Limbal blood vessels or some reference marks are used, and intraoperatively these are overlaid on each other, and as a result we get a nearly perfect axis of placement. So now coming to toric IOL rotation. Why it is important? Because 1 degree of misalignment will result in 3.5% of residual cylinder, and 3 degrees will result in 10.5 percentage of residual cylinder. However, if it is rotated 30 degrees or more, there is a total loss of the astigmatic correcting effect, and the patient needs redialing. Now, characteristics of toric IOL rotation. Various studies were conducted, and a consensus of various studies was found, and then they put up various points, as in why the toric IOL gets rotated and what are the factors contributing to it. So we'll be going through them one by one. So the timing of toric IOL rotation. Generally, it was found that within the first 3 days post-operatively and maximum between 1 hour to 1 day after surgery, there was toric IOL rotation, and it was found to be least between 1 month and 3 months after surgery. And the reason was found to be capsular fibrosis occurs around 2 months after surgery, so less likely that the toric IOL will rotate after that. And direction of rotation, there was no particular direction in which the toric IOL will rotate. It can rotate clockwise or anti-clockwise. Now, evaluation of rotation. Now, when the patient has come to us with a rotation of IOL has a cylindrical error post-op, so how do you check for the rotation? Like we use the objective method, that is the eye trace wavefront aberrometry. However, if it is not available, the subjective method is a slit lamp equipped with degree marks on the beam. So as you can see, the image is showing a slit lamp image, retroillumination image, and a proctor is applied, and as a result, you can see the degree marks. The IOL is oriented at 90 degrees. Now, the risk factors for IOL malrotation, we'll go through them one by one. So, biological parameters, characteristics of toric IOL, surgical factors, and miscellaneous. Now, biological parameters, long axial length, large dimension of the capsular bag with the rule and oblique astigmatism were the biological parameters which were found to have maximum number of rotations of toric IOL. The long axial length, since the eye has if the axial length is long, the width of the capsule will also be wide. And since it is a long axial length, thinner IOLs are used in patients who have a long axial length, and thus a smaller volume is volume needs to be used. So thus the contact between the IOL and the capsule is reduced. Also, if it is a wide capsular bag and a thinner IOL, there is more chances of capsular contraction syndrome, and it can become asymmetric. It can be an asymmetric contraction, and as a result, there could be rotation of the IOL. The main purpose of the entire study or the entire IOL to not rotate is just to make sure that the IOL and capsule stay in contact, in adequate contact with each other, so that they the IOL does not rotate. Now, the dimensions of the capsular bag, the white to white, more than 12.5 mm, age more than 70 years, and the lens thickness more than 4.48 mm. Now, what is white to white? If we go back to our IOL master, so you can see below axial length, we have the anterior chamber depth, and then we have the lens thickness and the white to white. So white to white is basically limbus to limbus cornea, limbus to limbus of the cornea marking. So if you subtract 1 from white to white, you will get a rough estimate of the capsular bag diameter. So if it is about 12.3, the capsular bag, we can say it is about 11. So if the white to white is more than 12.5 mm, it is a risk factor. Age more than 70 years, it is a risk factor. However, no particular conclusive studies were found to be related to age of the patient. And the lens thickness, if it is more than 4.48 mm, is also a risk factor. And also, if the IOL is vertically fixated, that is 6 to 12 o'clock, there are more chances of rotation. Then the characteristics of toric IOL, C-loop haptic design, PMMA material, and small toric IOL diameter. So, one-piece C-loop haptic had a better rotational stability, but plate haptic overall has a better contact and 2 positioning holes, and also it allows the positioning hole allows some lens epithelial cells to migrate. So this a small amount of lens epithelial cells, if they migrate, they create a contact between the IOL and the capsule, thus preventing rotation. Newer generation IOLs, toric IOLs, such as the Minivel Toric Ready and the Technis Toric 2 IOL were designed to make sure that there was no rotation, and they modified the IOLs by, for example, the Minivel Toric Eye Ready has 4 fenestrated haptics to enhance the surface area of contact, whereas the Technis Toric 2 IOL has frosted haptics to increase friction. So this is the first image is a Minivel Toric IOL. We can see there is 4 haptics and positioning holes as well. And the Technis Toric 2 has frosted haptics. So frosted haptics or the fenestrated haptics will increase friction and thus enhance more contact between the IOL and the capsular bag. The PMMA material was found to IOLs made of PMMA were found to have more rotation, and hydrophobic acrylic IOLs had stronger adhesions due to starch effect and fibronectin content. So if we see as per the different materials of IOL, the best ones for toric IOLs are hydrophobic acrylic IOL, followed by hydrophilic, followed by PMMA, and the last ones are the silicone IOLs. Also, the size of the IOL is important. Diameter of 11.2 mm will cause less rotation. But if it is small diameter IOL, 10.8 mm, then there is less chance of then there is more chances of rotation because there will be excess space in the capsular bag for the IOL to rotate. In this image, we can see that the A picture is a plate haptic. So the various brands which manufacture plate haptic IOLs are Alcon, Johnson & Johnson, Zeiss, Renar, and Star Surgical. Whereas C-loop haptics, again, Alcon, Johnson & Johnson, Zeiss, Bosch & Lomb, and Renar. These are the hydrophobic acrylic toric IOLs. The first one is the Acrisoft, C-loop haptic, AMO, and the Trueline. The Star Toric IOL is basically a silicon IOL. Now then, surgery factors. So if, first of all, there is inaccuracy in marking. So if you are marking manually, it is better to recheck with another method as well, so that you don't have any refractive surprise post-operatively. Or if you are using a digital method, you should always have a manual method as a plan B if at all you find some difficulty using the digital method. For example, Callisto, Varion both use the limbal vessel anatomies and location as reference points. However, if the patient has some chemosis or some bleeding, then there is a chance that the digital system might also make some mistake. So you should always have a backup plan of manual methods ready. Unsuitable CCC. So the CCC size should be approximately, for example, if the IOL size that are regularly used is 6 mm, the CCC should be 5.5 mm. 0.5 mm all over the optic, the capsular bag should cover. The capsule should be covering so that there is less chance of rotation. Post-operative hypotonia, incomplete removal of OVD. Grade 4 ACO, NDAC laser posterior capsulotomy, and if the CTR was not implanted. So we'll see them one by one. CCC, like I said, it should be well centered, covering 0.5 mm of IOL. Use of BSS hydroimplantation ensures complete IOL fixation on the posterior capsule. The viscoelastic, if it is retained behind the capsule, it will not allow contact between the IOL and the posterior capsule. As a result, there are chances that the IOL might rotate. However, if we totally avoid viscoelastic and use BSS for that is hydroimplantation of the IOL, then there are more chances, more likely that the IOL will be completely fixed on the posterior capsule. Now, anterior capsular opacification, basically it has a negative relation with IOL rotation. So if we see that, that if there is more anterior capsular opacification, there are less chances of IOL rotation. So between grades 0 to 3 ACO, higher grade will promote more stability, and that is capsular shrinkage due to fibrosis reduces the space for IOL rotation. That is why grade 3 ACO is better as compared to grade 0 ACO. However, this rule does not apply for grade 4 ACO, because if there is excessive capsular back contraction, there will be anterior folding of IOL and there will be optical decentration or tilting. The risk of all of these rotations are less with hydrophobic acrylics, like I said. And PCO, it will cause posterior capsular opacification, will cause asymmetric capsular contraction, which can lead to IOL rotation. Now, the catch here is we want ACO, that is, we want anterior capsular opacification. So, we can, towards the end of our surgery, we can leave a certain amount of lens epithelial cells or in the bag to promote anterior capsular opacification, and thus making sure that the IOL stays in place. However, if we leave lens epithelial cells in the capsular bag, it can lead to PCO, and PCO in general will cause asymmetric capsular contraction and can promote IOL rotation. So we have to maintain a balance in between achieving IOL stability and not promoting PCO. Now, points to remember: the capsular bag, if it's tight and the zonules are in gate shape, it is less likely to bunch up around the haptics than if the zonules are loose. By the same token, the stiffer the haptics of the lens, the more likely there is to be rotation. So if you have a stiff haptic and a stiff capsular bag, you will see more rotation than if the haptics were soft and the bag was soft. Now, what precautions can we do? There were various studies that were conducted, and they found that if you use a CTR, capsule tension ring, during toric IOL surgeries, it promotes more of capsule and IOL contact and reduces the chances of IOL rotation. So, if CTR was strongly recommended for lens thickness more than 4.45 mm, white to white more than 11.6 mm, and high astigmatism. Then the diligent removal of all viscoelastic from the capsular bag, including behind the lens. This is important, or else you can just completely skip this part and go for hydroimplantation. Otherwise, you can use a cohesive viscoelastic, which may slightly reduce the rotation risk because it is less likely to coat the haptics and will remain in place as compared to a dispersive viscoelastic. Nailing the capsulotomy to ensure 360 degrees of capsular overlap with the optic, because its increased contact helps prevent lens tilt and rotation post-op. And leaving the eye somewhat soft relative to the patient's usual ocular tension at the end of the case, so that it will allow proper collapse of the capsular bag around the lens. Now, management, like for this case, repositioning or redialing surgery is to be done. However, if the toric IOL rotation exceeds 10 degrees from the intended axis, only then a repositioning or redialing surgery is to be done. The timing of the repositioning surgery is generally 1 to 3 weeks. In case of recurrent rotation, transcleral and transcapsular suture passage through haptics in two opposite directions can be done. And for residual astigmatism, excimer laser, arcuate keratotomy, PRK, IOL replacement, or piggyback IOLs can be used. Thank you.
Yes, so Dr. Neha, you didn't mention how to calculate IOL rotation. If you don't have eye tracy,
Yes, sir.
then how do you rotate? How do you decide that which IOL axis you have to rotate back it to?
Sir, like I said, to check for the IOL rotation, slit lamp beam, which is marked with degrees or a proctor, that can be used to know why if the lens has rotated or not. We know the previous axis where we wanted to implant the lens, and then based on the slit lamp examination, we can check if the IOL has rotated or not.
But sometimes the previous IOL calculation itself may be wrong because the keratometry axis might have been taken wrongly.
Okay.
Also, surgically induced astigmatism will also change the new IOL axis placement. So, you know any website which gives you like how much we should rotate or to which axis we should rotate?
No, sir.
Sometimes there might be patients who are not operated at your place
Okay.
and they come with a high cylinder post toric IOL surgery and then you have to operate. So, how do you decide?
Um,
So, on online ACRS calculator is also there or astigmatismfix.com is there. On that website, you have to mention the IOL axis which is at present, like post-operative, what is the IOL axis,
yes, sir.
and then you have to mention the refractive error and the pre-operative or post-operative keratometric values. And then it will on that website it will tell you how many degrees you have to rotate the IOL to get the best correction.
Okay, sir. Yes, sir.
Okay, so you should not depend on pre-operative calculation or you may not have access to eye tracy in all centers.
Yes, sir.
Second thing, Alcon Johnson and Johnson, they don't have plate haptics. They just have the C loop haptics only.
Okay.
Okay.
Yes, sir.
So rest of the things were good. So we I generally use hydro, this thing, cohesive viscoelastic, which is useful because as you have mentioned that it one thing it you can remove it completely from the bag easily, and second it doesn't coat the haptic, so the chances of adhesion are more.
Yes, sir.
Okay. So plate haptics for normal size bags, they do really well. And so most of the hydrophilic IOLs, if you want toric IOLs in hydrophilic material, then it's better to have a plate haptic device.
Okay, sir.
Any other question from students? So, and can you go back to the IL master?
Yes, sir.
Why did we order a customized toric IL in this?
So the toricity was found to be 6 diopters. That is,
Six diopters are available in routine regular IOLs also. You don't need customized. Why customized? Okay, suppose you have to correct four diopters of astigmatism. What do you think will be the IOL toric power?
uh,
Yes, anyone? So the factor is around 1.4 to 1.5. So if you want to correct one diopter of astigmatism, you should use 1.5 diopter toric IOL.
okay.
So here the astigmatism is around 5.5.
Yes, sir.
So the patient requires toric IOL power of around 7.5 to 8. You can see that below the toric
Yes, sir.
calculation, you can see that
Yes, sir.
18 diopters plus 7.73 cylinder at 169. So
Okay.
it is not six diopters. Six diopters is the one which is available in most of the most of the manufacturers readily.
Okay.
But above six diopters, we have to get it customized.
Yes, sir.
So we used a power IL of 8 diopter cylinder in this case.
Okay, sir.
So that's why we customize. For left eye, because it is less than six diopters, it was available in the routine IOLs.
Okay, sir. Yes, sir.
Okay.
Yes, sir.
So customized toric IOL, this one was from Carebook, has a plate haptic hydrophilic design.
Okay.
All customized IOLs are usually in hydrophilic form. Why?
So it is more foldable and
No, customized IOLs are lathe cut IOLs. So you don't get hydrophobic IOLs easily. So hydrophobic IOLs, few of them are cast molded. So you have to have a cast for that IOL power, which is not possible for a customized IOL. So most of the customized IOLs are hydrophilic because they are easy to lathe and create. So we can have hydrophilic IOLs of any power which is possible.
okay.
So if you want say 50 diopter IOL, then it can be prepared in a hydrophilic IOL form. Okay.
Yes, sir.
Okay. Any questions from students? When do you when do you suggest toric IOL to patients?
Uh, Correction of astigmatism, and the patient does not want any spectacle dependence.
Suppose patient has 1.75 diopter cylinder and say steep axis is 90 degree. Then do you advise toric IOL for this patient?
Mm, no, sir.
So you should read more about toric IOL for calculations, how they are calculated.
Yes, sir.
Okay. What is the effect of surgically induced astigmatism? What is with the rule astigmatism and against the rule astigmatism, and how does it affect? your toric calculation. So difference between, suppose patient has one diopter against the rule astigmatism and one diopter with the rule astigmatism, then which IOL, which astigmatism will induce more post-operative cylinder?
Against the rule.
Why? So you have to read about posterior corneal astigmatism also. That is also important. Okay.
Yes, sir.
So many things you have to read
Yes,
after this. Okay.
yes, sir.
Okay. Thank you.
Thank you
If
so
there
much.
are no other questions, we'll stop.
Yes.
Okay. No questions.
No, sir.
Oh, thank you.
Thank
Thank
you.
you, sir.